Now invite Dr. UNNIKRISHNAN Nair, who's the director of Chaitanya Hospital, Trivandrum, and he would be speaking on prevention and management of post-surgical hypotony, and probably we can take up some questions after that.
Okay, thank you for the intro, and there's going to be a little bit of overlap between the last talk, but this is, as I said, there is a statistical definition of hypertony, and there's a clinical definition which Dr. Divyansh has mentioned. And basically, to divide everything simplified, there are two methodologies. One is because of an aqueous outflow, that is external fistulation, which may be to the exterior or the subconjunctival space, where you can have corneal lacerations, scleral lacerations, or a filtering surgery, which is the external fistulation, or internal fistulation like cyclodialysis and the works. But there is also one more circuit that is called the posterior circuit, internal fistulation, where when you have an exposed RP, an exposed choroid, there is an increase in the uveoscleral outflow. So there is no necessary direct communication to the outside, but there is more absorption by the RP pump or osmotic gradient through an exposed choroid. So that is called the posterior circuit, or the posterior removal of aqueous. A ciliary body insufficiency, as Dr. Divyansh has mentioned, by extensive cyclodestruction, and inflammation as a major cause of reduced production of aqueous. So these could be the major pathophysiological causes, but it can be broken down to two, that is decreased inflow because of ciliary body damage, and increased outflow because of fistulas, holes, or the posterior circuit, as we mentioned. So while looking at hypotony, one is a definition of low pressure. The functional changes, it may be symptomatic or asymptomatic, and the structural changes, which is important to realize in this concept. There is a transient phase of hypotony, which, if not treated aggressively at that stage, it goes into chronicity, and probably it becomes more and more difficult to treat. So I'm just going to skip this. So evaluating any hypotony from a management perspective, would we look at the circumstance, understand the mechanism, look at the prevention at that point, and the treatment. So some of the scenarios we face hypotony, post-surgical, post-operative, are these scenarios. And let's look at cataracts. So the circumstance could be a leaky corneal wound, an occult cyclodialysis, or a choroidal detachment. The mechanism would be, as we said, if it's an occult wound or a thing, it would be an external fistulation. If it's a cyclodialysis, it would be an internal fistulation. And if there's a choroidal detachment, it is a mechanism, as I said, the posterior circuit of removal. The prevention is, after a cataract surgery, when you see a shallow bleb forming or a hypotony, to inspect the wound properly. Avoid a lot of AC maneuvers while doing violent or inflation or all those maneuvers while doing cataract surgery, and prevent a sudden intraoperative hypotony, which can create the choroidal detachment and start the cycle of hypotony. So after cataract surgery, what would be the treatment? That is, inspect the wound. If there's a wound, leak, an AC reformation, a compression bandage, and observation would be a conservative way. You can wait for a few days to see if the wound closes up or becomes competent, or an inverted bleb that is created can be collapsed. There is a controversial way of reducing flow through an occult fistula, that is to reduce the IOP even further, and then the flow reduces, it closes, and then it builds up after that. But there is a small danger regarding that of worsening the hypotony. Cyclodialysis can be diagnosed using a UBM and anterior segment OCT, and traditional treatments are diathermy, laser, and cryo. Direct suturing and AC reformation can be done. Choroidal detachments, usually in the transient phase, they can resolve spontaneously, or a drainage with AC formation may be required. So let's look at just another point, is that hypotony can also cause cataract. So the hypotony, there are hypotony associated, nearly 33% of patients with hypotony develop cataract in a very short period of time. So after filtering surgery, what is the tendency of hypotony? One is you have your aim target IOP and you overshoot it by your surgery, or the hypotony that's induced by antifibrosis agents or the incidence after aqueous shunts. So in filtering surgery, a sudden drop of IOP and overshooting could be one of the things that start the cycle of hypotony. And we know that in the previous full thickness surgeries, you had extremely high rates of shallow ACs and choroidal detachments, which are less over time. The antifibrotic agents have, by nature, they are supposed to reduce the fibrosis, reduce the scarring, and increase the drainage. But by nature of their chemical nature, there are some effects like inducing a ciliary body inflammation, which could contribute to more reduction of the IOP than is expected by their antifibrotic effect. Aqueous shunts cause transient hypertony. And there are many mechanisms, including tube ligation, occluding the stent, doing it as a two-step procedure. But one thing that has to be noticed is that when you do an aqueous shunt in an aphakic patient or a vitrectomized patient, the chances of developing a transient or hypotonia are higher. So the prevention could be to do a really good gas fill if it's a vitrectomized patient, to reduce the incidence of post-operative hypotony. And just for your information, double shunts cause more hypotony. So if you expect a patient that is going to go, you can use a single shunt device, single plate device, and concurrent use of mitomycin could also be a feature that has to be avoided. So other procedures that can produce are cyclodialysis and cyclodestructions. And I just want to touch about the post-operative inflammation. See, the post-operation, the inflammation component is there in every surgery, and sometimes an overwhelming inflammation produces a transient hypertony. So this is the stage where it has to be dealt with, and the chronicity should be avoided. And after vitrectomy surgery, as Dr. Divyansh was mentioning, there is a convexity of the globe, tension of the globe, which is altered sometimes in vitrectomy surgery, and and this was previously called the hypotony syndrome or the iris root retraction syndrome, and could be associated with anterior PVR changes. So the role of vitreous generally is it's thought to be a hyaluronic acid plug, which plugs in a patient who is aphakic. If the possibility of the excessive outflow is reduced by the vitreous, the hyaluronic acid in the vitreous, and that is why a vitrectomized eye could be more prone to hypotony. So these are some of the, as I said, the large breaks, having large retinal detachments, the posterior circuit coming into action. The presence of rubeosis is a tendency because of the drop to form hypertony. Chronic inflammation produces membranes, and all these, I think this is going to be dealt with later. So I just want to put in a small algorithm first. If it is transient, look for the immediate post-operative causes, wound leak, cyclodialysis, and you can observe. But the main point is to prevent the transient from becoming chronic. And when it becomes chronic, there could be an element of chronic inflammation, ciliary body membranes, and increased outflow through the ciliary body and the posterior circuit. And then definitive treatment like managing the inflammation, surgery could be assessed. So I'm just showing a small couple of videos here. Here, what is shown is in this video is a bleb in which a limiting suture is being kind of placed all around it to limit the filtration area. This is a delimiting suture around the bleb to reduce the area of the bleb expansion over here. You can see the suture going around and the changes. So this is, the next one is a very, this is just to reduce the filtration. It's a autologous blood injection to reduce the, delimit the bleb so that the fibrosis happens on the side and reduce filtration. Here you can see the compression sutures on the bleb, which is used to reduce filtration. And this is something that I have used. It's not officially recommended, but sometimes all of us know that difluprednate causes a raised IOP. So sometimes in cases of transient hypotony, difluprednate can cause an increase in the IOP. But it's a double-edged sword to use it sometimes. And this is something that I've done in a few patients, which I'd like to highlight. It's the encirclage technique. When you have an unexplained hypotony, as we had in this particular patient, you can just do, an encirclage procedure. The point is that it reduces the UV, it kind of compresses the the external, the UV scleral outflow sometimes, and if there is occult flow through to the posterior circuits reduced. So this is a simple buccal procedure. But I just wanted to show you the results of what this is. A patient who had this is a silicone oil filled eye with hypotony. You can see the disc edema, the folds happening, and we just put a buccal which was slightly more anterior and a bit high. And over time, you can see that the venous congestion has come down, the disc edema has come down. And this is a patient who but this is the last one, this is the beginning and the end picture, while just an encirclage has reduced and treated the hypotony to such a level that the disc edema has come down, the vascular dilatation has come down, and the macula, that's an artifact in the center, but the macula looks okay. So to summarize, the circumstances of hypotony could be varied. The mechanisms are either an inflow reduce or an outflow excess. The prevention is proper surgical technique, and the treatment in most cases is to treat early. The concept is to treat early when it is transient rather than it getting fixed and becoming chronic. Thank you.
Thank you, Dr. Unni, for elucidating all those various causes of hypotony. Are there any questions from the audience? So I have one question for you, that if you are dealing with a patient with a retinal detachment with choroidal detachment, apparently there would be an underfill of the silicone oil if you decide to operate immediately. How do you post-operatively follow up this patient, and when do you plan to go back and do a little top-up of oil?
Is it from a perspective of detachment repair or a perspective of hypotony?
Hypotony.
So generally, as I would say, I don't think the oil is going to contribute. The underfill of oil is not going to contribute to the hypotony. It is basically the reattachment of the choroid and the retina that is going to be more important. So even if it is an underfill, if the oil has done its job in reattaching the retina, having an endotamponoid at that point of time, it may go through a phase of transient hypotony, but the main point is that if you have reattached the retina and the choroidal settle down, the underfill is not going to be contributory towards the hypotony.
Any comment from you, sir?
I would agree with Unni, and usually retinal detachment, choroidal detachment, you drain the choroidal detachment, and most of the time, nearly about 90% of the choroidal detachment is drained before you are able to fill the tamponade. So, and it's usually a fresh RD. You may not even be using oil, so you may be using gas. Nice. So I don't think it's too much of a concern as far as hypotony is concerned.
And would you opt? Yeah, please go ahead.
In I would titrate this. This ended up a little bit high because of two reasons. Because you're operating on a hypertonous eye. One, but the only modification I do is that for me the encirclage would be more closer to the muscle ring, more anterior, because the concept is not an aura creation or a tampon or an buckling effect. The idea is to break a circulation from occult cyclodialysis or from generally a UV scleral outflow. Yeah, it is. I have to be honest, this is a patient who was a uveitic patient, both eyes operated, both eyes with silicone oil inside, both eyes with hypotony. The left eye worked very, very well. The right eye, the minute I put it inside, it pushed all the oil into the anterior chamber. Then I had to struggle to manage that. And the right eye is always a little bit worse than the left eye. The pressures have just come to about 6 or 7, 6, 7, 8, but the disc edema and the macular folds have ironed out. So, yeah.
So, I just wanted to ask you, very typically we get these children with JIA, and they are the ones who have actually undergone an IOL implantation with a lot of chronic post-op inflammation. And despite having explanted the IOLs, they continue to have very, very bad chronic hypotony. Even if you put in silicone oil, then they start developing a BSK. In those situations, any role of an oil retention sutures?
Oil retention sutures generally are required when you've taken off the iris also. When it's a totally aphakic patient is when you put crisscross oil retention sutures. When there is some amount of iris, it usually keeps even if it's aphakic, it keeps the oil behind. But in these patients, again, it is the pathology that is happening at the ciliary body level that is more important than the detachments, whether it is inflammation or whether it is
Yeah, but
epiciliary
despite the
membranes.
iris being there, because of the chronic hypotony, you tend to have the oil all the time coming into the
Yeah.
AC, and probably that's contributing to the BSK.
Yeah, so what I have seen is that placing an IOL is a key feature over there in some methodology. The second is using oil retention sutures are okay, but again you are passing your crisscross sutures very close to a damaged pars plana and very damaged areas.
Can I add something? In such a situation, if the iris is still okay, it's not retracted, then I would probably think of doing a pupilloplasty. Rather than doing an oil retention suture, you can probably make the pupil smaller so that the oil doesn't come into the antechamber. Why oil is coming into the antechamber in this patient is because the ciliary body is not secreting. So you would probably make the pupil smaller so the oil doesn't come into the antechamber, despite which it may come. So you'd probably use a 5000 centistroke oil and make the pupil smaller.
Dr. Divyansh, any role of posterior subtenon tricot?
So yes, that's the last resort which we try, but whether it actually works or not, the answer is very difficult to suggest, because what we think that the steroid is causing a trabecular meshwork scarring, and that's where the outflow is getting occluded, and whatever the inflow, or means whatever this aqueous has been produced, it is expected that it would stay in the eye. But it all depends whether the ciliary body is functioning or not, and then is when the whole answer of whether the means that's the final resort. Because there is one more drops I forgot, not the difluprednit. There is
there was something which was mentioned about 3-4 years back. There was a literature on it, and we tried getting it. I'm also unable.
I would source and let you know. But there is one of the drops which
was not available in India. There was a trial where it did increase the intraocular pressure by about 3. It's not available in India. That's right. What was the name again, man?
I'm just.
Okay, sure, that's right. Yeah, it increased by about 3 to 4 millimeters, if I remember right. Yes. Right. And so, despite what Divyan said, it's not as though subtenon steroid is the last resort. The fact that we don't get to do something, we want to do something, so we keep injecting subtenon steroid quite often. Whether it works or not.